Dear colleagues, today I'm going to talk about bacterial resistance in animals and the implications for human health in a One Health perspective. And I'm going to go back in time and discuss about what have we learned from the past. Have we learned something interesting from the past? Do we have data that we can learn from? Okay, as an introduction, I have a little picture there also, and you can see in the center is human health. So this is very anthropocentristic, and if you look very well here, we go from the animals to the humans, and then there's some things around it. So it is the animals that is the problem. And indeed, there have been several episodes in which resistant problems in human medicine have been attributed to animals. But was that in fact so? And what has been proven in the past? So I'll go over these episodes and see what has been done. Now, first, that picture was a little bit anthropocentristic, and then here we have a little bit more a more detailed picture, and we can see that we have the human on one side, we have the animal on that side, and we have also the aquaculture. And in between, we have all kinds of other things like the environment. We have also the companion animals, sometimes much forgotten, so that happens also. And then we have also vegetation, seeds, crops, fruits. Antibiotics are also used, for example, on fruit trees to treat fire blight. So this is already a more comprehensive and a more complete picture of what One Health can be. Now, recently, the Joint Action Plan, the quadripartite, has proposed another picture of One Health. And we see here that One Health is central and One Health is compromised in equal parts of different systems. So we have healthy humans, healthy ecosystem, and healthy animals. Now, One Health is not only about health, it is also about the society. So the society plays an important role also in One Health. How do we behave? How do we have access to healthcare, which is in some countries very problematic? There are lots of differences at the local level, the national level, the regional level, and so on. So also society is important and how people think. The sectors and disciplines involved is environment, human and animal. We see that here also depicted in the One Health picture. And then we have to do something with that to come to One Health. And here we talk about communication, collaboration, openness of data, for example, is very important. Coordination, things have to be coordinated between the society and the health systems, and we have to do also capacity building. It's very important, seeing the problems that some countries have to build up a healthy system, not only for healthy humans, but also healthy environment. Let's think about waste disposal. That is in some countries quite a difficult problem. Not only waste as such, but also waste from antibiotic production plants, for example, who contaminate the environment. Okay, but let's go back in time. And in the 1990s, we had the story about vancomycin-resistant enterococci. So vancomycin resistance in enterococci has been selected in human medicine by vancomycin, the use in the clinics, and we could see that very well in the US, where vancomycin has been used for the decontamination of the intestine before surgery, but it has also been used as growth promoter in animal health. In animal health, not really animal health, but in animal production. So in Europe, the first reaction when the VREs came up is that the vets were responsible because there were vancomycin-resistant enterococci in the animals. But there was a low prevalence of vancomycin resistance in humans in Europe and a high prevalence in the US. But in the US, avoparcin, that is glycopeptide, was not used as growth promoter. And then further on, when we had more capacities, we saw that the enterococci causing these hospital infections were a very specific clonal complex that was not present in animals. So we had the same genes, that's true, but what does that mean? How does that go from these genes to the human environment? And if we look a little bit further, we see also that humans only can get temporarily infected with VRE. So infected mean colonized, but they don't stay, so they pass through. The resistance can indeed be transferred, but we can't estimate the importance in there because the selection pressure in humans is also of importance. So what is the contribution of this transfer, in fact? We have the VRE causing problems in humans that are very different from the animal clones, and we see that the problems in the US were caused by use in humans only. So the question remains, what was the contribution of the animals into the resistance in humans? Was that minimal, or what was it? It's still not covered, but it's definitely not only the animals. Now, 10 years later, more or less, we had the extended spectrum beta-lactamases. Now, the story about the extended spectrum beta-lactamases is that it was first discovered in humans in the 80s, and in animals only by the end of the 90s, and then it was still very low. So what did we have then, like in the 2000s, the early 2000, let's say 2005, we see in certain animal species that there is a very high prevalence, and the same genes are present, but at a different distribution. They are present in different proportions. And indeed, here also transfer is possible. It's frequently plasmid located. So we see that it can transfer, in fact. We have also these ESBLs in Salmonella, and we know Salmonella is a zoonotic pathogen. So the ESBLs selected in the animals in Salmonella are definitely from Salmonella origin. I think that is quite clear. However, there was these differences of different genes, the proportions that were so different, and the possibilities of humans to get infected with animal E. coli is extremely low. The population is very diverse, in fact. So what have we been estimating as possible transfer? In the beginning, it was estimated at like 60%, but then more data and more technologies came, and we saw that, in fact, the contribution was like potentially 10%, and sometimes it couldn't even be demonstrated. So it might have been difficult also. Now we see in 2005 that we have methicillin-resistant Staphylococcus aureus, and that came in 2005 more or less, and there was panic in the Netherlands because the pigs were positive, and they have a very specific hospital policies in which they search and destroy MRSA. So they treat the patients before they go into surgery. Now with MRSA, we have this specific clone ST398, and this one doesn't really infect humans too much. It has been a human clone, but it adapted to animals. It lost its host specificity, in fact. And it is not really a pathogenic strain either. Now, bacteria are not sitting still, and they're very smart. So this clone is evolving and potentially getting more pathogenic from humans. Other STs are getting also resistance that we see geographical differences, in fact. But currently, as for human health, the contribution of MRSA to human health is still minimal, in fact. And if we look also to when MRSA was seen, then we see that it was way before it was found in humans. First cases in humans were in the 60s, so it was only like 40 to 50 years later that it came into animals. Now we see something very special with a specific situation in South Africa where we see in animals MIC-C mediated resistance, and that has an association with wildlife, and wildlife can be regarded more or less as the environment. Now in Europe we don't have a lot of wildlife, we have some hedgehogs, and we saw that potentially these MIC-C mediated MRSA came from hedgehogs. In fact, in South Africa you have a bigger wildlife proportion. So here you can see that the situation is different, and for the moment there are very few studies done. In fact, in South Africa we see MRSA only with MIC-C. We have recently figured out also that you have hybrid MIC-A MIC-C methicillin-resistant staphylococci in animals. Though not methicillin-resistant staphylococcus aureus, it's coagulase negative staphylococci or mammalia cocci. Okay, that was MRSA. Now we have colistin resistance, and that was first detected in China, and they found it also in humans. However, colistin has been used since the 60s, so that popped up very late. And what we saw also is that not only because it was detected in China, but even in Belgium, we had a higher prevalence, especially among pathogenic E. coli from pigs. And well, polemic, since colistin is used a lot in the treatment and prevention of E. coli infections in pigs, but also in bovines. Now, if you look at MCR prevalence in human bacteria, whether it's E. coli or other Enterobacteriaceae, it's 0%. So this hasn't gone to the human population in Belgium. So we see in human medicine, we see colistin resistance, of course, but it's mainly mediated by point mutations, and it's mainly in bacteria like Acinetobacter and Pseudomonas. Okay, there we go. So here we also have the question, what is the contribution to the resistance in humans? It is minimal, perhaps. In Belgium, it's not seen. There's no obvious transfer to human pathogens. In China, it's found in human bacteria. But why is it important now? It's because of colistin being the last resort antibiotic for multi-resistant gram-negative bacteria. So, in conclusion, what do we have? What is the proportion of resistance going from animal bacteria to human bacteria, or animal bacteria that go to human? If you look at these stories, well, it is not clear, and it might be rather minimal. If you're talking about zoonotic pathogens like Salmonella, that's obvious. So we didn't see any major impact, nor in VRE, MRSA, ESBL, or other bacteria. And we still have to figure out what is in fact the importance of this transfer of resistance between animals and humans, and we know even less about the environment. I thank you for your attention.